Two.
Hello, everybody. Welcome back to the podcast. Today, I welcome back on Dr. Bryan Treacy for a second conversation. In this conversation, we're going to address some comments that came up on our last conversation, specifically about fibroids, and a few other things that came up. But before we get into that, in case you didn't listen to our last conversation, a little bit of introduction on Dr. Treacy. Dr. Treacy has been an OBGYN for over 30 years. He has extensive experience in women's health. He has performed hundreds of hysterectomies, myectomies, and also delivered many beautiful babies. Um, he then, as his career progressed, recognized there was limitations in what we would call traditional or conventional medicine, and he decided to transition into a more holistic approach. So now he offers holistic health consulting, and he tries his best, although Dr. Treacy, it's hard nowadays with all the conflicting evidence to blend what we would call science and his broader understanding of wellness. How are you today, Dr. Treacy? Thanks for coming back.
Thank you. Yeah, I'm great. I'm fine. We got a blast of winter here last night, so hopefully we're headed back to spring tomorrow.
One can only hope.
You hear
I
me?
think I think we have a
Yeah.
little bit of a delay between us, so if the audience will just allow us a little bit of grace. It didn't happen before, but hopefully our connection will catch up.
Okay. Yeah, I've got full power, so I'm good.
Yeah, it just seems to be a time delay. Regardless, on our last conversation, we discussed many things. It was an awesome conversation. We specifically spoke about hysterectomies, myectomies, and then we got into the conversation around fibroids. And we shared a reel on Instagram, which then kind of blew up, especially around women and their experience with fibroids.
Right.
Well,
We
we
did, yeah. That one got lots of comments.
And I can see where the confusion was, so we're going to get into that, I think, and answer some of the comments or questions. Um, so you have a lot of experience with fibroids from your 30 plus decades career. Let's start simply, just so women understand what are fibroids and are there different types of fibroids?
Well, most fibroids are benign. So when you tell somebody that they've got a growth on their uterus or they have a tumor does not mean cancer, and fibroids rarely are cancerous. So they're there. 75% of women have them. So if you look with ultrasound, you're going to find them. So you could almost make the argument that having fibroids is normal if over 75% of women have them. The problem is when they outgrow their blood supply and they start degenerating. So it's a fibrous tissue that has a capsule. It is not made of muscle. So the uterus is a smooth muscle, and a fibroid is fibrous tissue, basically, that grows or doesn't grow. A lot of times they're there and they don't do anything, they just are there. So those are the ones that, to me, don't worry about. A lot of women get talked into a hysterectomy because someone will see that they have a fibroid and say, well, we better do a hysterectomy before this fibroid gets too big. And they tend to be estrogenic, so they like estrogen for food. So theoretically, if someone goes through menopause and did not have estrogen replacement, they would stop growing. The problem is the ones that grow kind of fast and they almost outgrow their blood supply and they cause pain because they start getting necrosis, and so they die from the inside out.
Mhm.
So, or they get so big that they cause pelvic heaviness, or they impinge on the lining of the uterus and they disrupt that normal flow. and and just cause trouble. So most of them are asymptomatic. Most of them, 99% of them, do not turn into cancer. There is a cancerous version called leiomyosarcoma. And sarcoma you think of with as muscle. The Latin base of that is tissue. So leiomyosarcoma, myo means muscle. It's not a muscle. And leiomyoma is the benign term for a fibroid. Does that help?
Yeah. So here's where the confusion lies, though. During our last conversation, I had mentioned that Dr. Geraldine Pryor had said that fibroids do not have a blood flow. And we discussed that, and you agreed and said, yeah, that's why we can remove them with myomectomies pretty easily. But then that's where the confusion seemed to spiral on Instagram. A lot of women saying, well, if they have no blood flow, how come I'm bleeding so heavy? The doctor found this fibroid, it was removed, and then my heavy bleeding stopped. And that's where the confusion came in.
It's the disruption of the lining inside the uterus that is shed. So if there's an impingement or a pressure or a growth that has stuck inside or protruded, I guess is the best way to say it, protruded inside the uterine cavity where you carry babies, that can disrupt that blood supply and that blood flow and that cyclicity, if that's a word, cycles, cyclicity, where that is disrupted and you get abnormal bleeding. But the fibroid itself, it does have a blood supply, otherwise it would die. But it doesn't, fibroids don't typically bleed into the uterus and have it come out. It's a
They're not
disruption of the
causing the
lining of the
bleeding.
uterus that causes it. That's right. They aren't bleeding themselves, but they may be causing the bleeding by disrupting that endometrial lining, that uterine lining that's shed during a menstrual cycle. So one of the things we talked about was uterine artery embolization for fibroids, which would of course disrupt part of the blood supply to the uterus as well, but it can also disrupt the blood supply to the fibroid. So typically, surgically, when I would take a fibroid out, called a myomectomy, at the very base, I would find a blood vessel. And so when you take one of these things out, you can open them up. You find the least deep part to get to the fibroid through the let's say the roof of the uterus. You have to go through the uterine muscle, and you can bisect it. So you use a scalpel or a electrosurgical instrument. You cut it in half while you pull it apart, and it'll come up, and you have it, and you put a clamp, or you can surgically cauterize the very base of it, and that's where the blood supply is. So you don't see vessels flying all over the place inside the fibroid. But in order for it to be alive, it has to have a blood supply. So the trick to a myomectomy is getting the myoma to bisect so you can get down to the blood supply and interrupt that, and then it just pops right out.
Okay, that makes sense. And I feel like we can all perform myomectomies now because you just described it so well.
Yeah. Well, it's kind of spooky. I mean, I got taught how to do it by my mentor. When I first did one, I was frightened because you're depending on the size of a fibroid, you look like you're destroying the uterus. But once the fibroid is out, you can understand how to put the uterus back together so it looks like a uterus. Not every surgeon can do it, I'm guessing. Otherwise, they would offer it because it's reasonably simple to do. It's not difficult.
Well, I would hope every surgeon knows how to do it. There was a comment on that Instagram feed saying that this lady was told the only option was a hysterectomy, unfortunately.
Well, that's true sometimes. I don't remember if I told you about the one that we did for a woman that had so many fibroids that her uterus was as big as a pregnant uterus.
No, you didn't. You did tell me
And
about
so
one that was very big, like a melon, but not multiples.
now this was we did this with a robot. So we did robotic hysterectomy, and my surgery partner and I, and her uterus was as big as a pregnant term uterus, and she wasn't pregnant. That was all fibroids. She did not want to be opened up, and in order to do a hysterectomy on her, that was really the only option for her. There was no way that we were going to take out all this huge, enormous fibroid and find the uterine tissue to be able to save her uterus. And she was, I don't know, 49 probably, if I remember right. And a uterus typically weighs about 60 or 70 grams. And when we did this hysterectomy, we did it robotically, so we had to kind of remove it in pieces. That makes sense. And when we put it all together and weighed it, this was a 750-gram specimen. So it was 10, 12 times the size of her uterus without fibroids. So it was a big deal. It took us 7 hours to do it, but we got it done.
Was this woman very estrogenic? Because as you mentioned before, estrogen fuels fibroids.
Mm-hmm.
Did she have other symptoms of high estrogen?
Not really. I mean, they are estrogenic. They do eat estrogen for food. So she was not menopausal. She was one of those women that I can't remember the whole story because this was several years ago, 20 years ago. And somehow that got missed. I mean, if you would have evaluated her, and my surgery partner and I didn't meet her until she had this enormous uterus. So if somebody would have done an ultrasound on her and said, "Oh, here's this fibroid," at a time where we could have just done a myomectomy on her, that would have saved 7 hours in surgery. So, but she didn't have any other symptoms other than the fact that she had this enormous fibroid, multiple fibroids that had grown over who knows how many years. She was not heavy. Women that are heavy tend to make peripheral estrogen in their peripheral body fat, so they're a little more estrogenic. We just happened to we didn't meet her until there was no other option for her but hysterectomy, and she was fairly miserable. She walked around. I mean, think how you feel when you're full term pregnant. You're
Mhm.
off balance. She had swelling in her legs. She just felt like she was going to tip over all the time. It felt like she had a bowling ball sitting in her pelvis, which she kind of did.
Mhm. Yeah. Well,
So
sometimes these,
interesting case, but we had
some,
no other option but hysterectomy.
yeah, well, that's obviously extreme case. So I suppose there, in
Yeah.
certain circumstances, there is no other option. But in some women who we would consider slim and healthy, they still have a lot of estrogen issues because detoxification pathways are impaired, or there's something else going on like thyroid that we can't see. So maybe she still had some stuff. Before we move on, I just want to go over this. I took some notes. I just want to go over these real quick so the audience understands what we're discussing in regards to like how it can be confusing when we say the fibroid doesn't have cause bleeding, but it does have a blood flow. So what we're saying is that the fibroids can contribute to bleeding through a couple of mechanisms, and please correct me if I'm wrong. There's obviously the increased surface area on the uterine lining. So if a fibroid grows into the uterine cavity, then it'll stretch the lining, and then the more surface area you have in the endometrial, then the more capacity you have for more bleeding or shedding during your period. And then we have distortion of the uterus, which you kind of touched on, where the fibroids can distort the change, or excuse me, the shape of the uterus. And then that interferes with the uterus's ability to contract normally during menstruation. And then this will cause blood vessels to compress and cause erratic bleeding. Then we have around the fibroid fragile blood vessels, because fibroids can create abnormal fragile vascular networks around them as they like grow into the tissue and they stretch the tissue, and this then can cause these blood vessels to rupture more easily during your cycle. Then we have hormonal signaling, especially local hormonal signaling, because fibroids produce inflammatory hormones and growth factors that can also alter how the endometrium responds to hormones. And this can lead to excessive bleeding. And then the last one is venous congestion. Very large fibroids can compress nearby veins, leading to pooling of blood in the uterus, which can cause and contribute heavier bleeding. So the fibroid itself is not bleeding, but all of the stuff I just mentioned influences the surrounding tissue, and that's what's causing your heavier bleeding. Am I right?
That is exactly right. Yeah.
Okay, good, because I just wanted everyone to be clear because there was so much confusion. Um, one woman
Then
in,
you then you add then you add in women that are going through perimenopause where they are estrogen dominant, so relatively progesterone not deficient but suboptimal, and then you have a mismatch.
yeah.
And so think how many women in their 40s have weird periods because of that. And then you throw a fibroid in the middle of it and make it even worse.
Well, this is one of the reasons why many women during perimenopause experience heavy, prolonged bleeding, because the estrogen fluctuates so much. But most women, at least that I work with, have like zero progesterone because they're career women, they have kids, they have stress. Now they're in perimenopause, and before that, they already had estrogen issues, and now maybe they have thyroid issues, and it just compounds. So then you see the growth of all these different tissues. There was one lady in the Instagram feed that said that fibroids can grow back after a myomectomy. Is that true?
Sure. You know, the question, of course, is what is the origin of fibroids? And they seem to be estrogenic, like you said. And somebody that's more estrogenic would tend to have more fibroids. But if 75% of women have fibroids, then it's, I'm not going to say it's normal, but it's more common than uncommon.
Mm-hmm.
So can they grow back? Yes, that means that there was something that they couldn't see with their naked eye that they could do a myomectomy on. So
Would it
if you had a small fibroid that had just started out, let's say a fibroid that was too small for bulging or creating a morphologic change of the uterus, that you know, how would you do you wouldn't be able to see it. So my guess is that they don't grow back. They've got myomas that can't be dealt with visually.
That was going to be my question. Would it be the same fibroid that they just removed that maybe they hadn't fully, or it was just another one that was starting to grow underneath it? So it's not growing back, you're just growing more.
Well, I suppose if you're growing more, my guess is though that like with an ovary, you know, I've had women that said, "Oh, I had both of my ovaries out, but their hormones were normal." So I would say, well, you you have some ovarian tissue in there someplace. Otherwise, your hormone panel would not be this way. So I have taken care of women that I went back to the operating room. I'm sorry, let me turn. Uh, I've gone back to the operating room, and they, in their mind, had had a bilateral removal of their ovaries. And sure enough, I'll go in there and find a little piece of ovary that's all covered by scar tissue and all that, that I would have to remove. So if you leave any piece of an ovary, and I think fibroids are the same thing, the same way. If you leave any piece of it and don't completely remove it, it's going to grow because it is responding to estrogen.
Mm-hmm.
But for the most part, if you do what I said earlier, where you bisect the fibroid and you keep peeling it apart, once you get the blood supply and you remove it, the whole thing it just comes out. It's kind of fun to do if you're a surgeon.
Yeah.
Because you think, ooh, that I'm not supposed to be able to do this. And it's very, very, not simple, but it's way easier than most surgeons think it is. So there are surgeons that would say, I'm not going to tackle that because it's too difficult. And a hysterectomy is easier, or as easy, maybe I should say,
But
depending on the size of the fibroid. So the 750-gram uterus was difficult. It took 7 hours to do it.
there was another woman, and you commented on this, but
That makes sense.
there was another woman, and I just wanted to comment, or you did comment on this, but I'm bringing it up again just for everyone's reference. This woman asked, if you remember, why UFEs, uterine fibroid immobilizations, were offered. Do you remember that comment?
Yes.
So
I can't
why
remember
are you?
so why do those?
Mhm.
Is that what you're saying? Well, they do have a blood supply, so you're basically cutting off the blood supply. And here's why, and I think the same woman or some other woman says, well, yeah, I had it done, but it was very, very painful.
Because you're
So
taking the
I would
surrounding
always
tissue.
tell women, well, you're infarcting a structure. So it would be similar to, think what would happen or what it would feel like if I took your finger and I tied a string like fishing line around and tightened it down as far as I could so the blood supply wasn't there. Your finger would slowly die and then fall off. Same concept. So you're creating a necrotic fibroid or a dying fibroid, and dying tissue hurts.
So they're not actually taking it out,
But it
they're
is
just killing it slowly.
they're killing it. Yeah. So that's why it's offered, because they do have a blood supply, and what they're after is that particular blood vessel to that particular fibroid.
Okay. Okay.
I'm not going to say I've got a lot of experience with embolization, because when I offered it, I'd say, okay, there's radiologists that do this right here. And I was in Oklahoma City. I said, they're here. If you want to explore that option, go talk to them. And some of them would talk to them and they would come back and say, nope, I'm not doing that. So most of the time, they were dealing with me as a minimally invasive surgeon, where I could tell them, I think I can take the fibroid out and leave your uterus, with the understanding that if I get in the middle of it and I have uncontrolled bleeding, I'm going to have to take your uterus out. So they always went in knowing that they may wake up and have had a hysterectomy.
Yeah.
And I can think of one where I couldn't do it. I was in the middle of it and I'm like, this is a mess. There's too much blood loss. I can't do it. One time.
So another comment, this one on Instagram said, I had what the doctors called a medium-sized fibroid, and I was bleeding so heavily every time I had a period that my anemia was so bad I needed an iron infusion every couple of months. I had a procedure where they blocked the blood supply, which is the UFE that we just mentioned there, I'm assuming. And that procedure caused the worst pain that I've ever
Yeah.
had for about 24 hours, but it worked. And now when I have my periods, they're back to normal again. That's the one I think you mentioned that you saw.
Yeah, that's how it works. It's very uncomfortable for most women. 24 hours is pretty interesting, really. You would think that it would last longer than that, but for her, everybody's an individual. There's always a different story.
Hmm.
So for her, Um, she had 24 hours of the worst pain ever, and then the fibroid died, infarcted and resorbed itself, presumably, and then got smaller. So if you cause necrosis, death means death. If you cause necrosis to a tissue, it's going to shrink.
So,
So that's how embolization works.
so then the dead tissue, what is left, does that just come out in your cycle, in your bleed? It just gets
No, your body
reabsorbed?
would resorb it. Mhm.
Interesting.
Your body's very efficient. It knows what to do with stuff that doesn't belong. So it'll eat it, it'll metabolize it. You got an immune system, you've got macrophages, you get things that deal in white blood cells that deal with tissue that is dying. I mean, part of regenerative medicine is putting yourself into autophagy by not eating so that your body can clean up debris. Usually happens at night. That's one of the reasons I tell people you need that sleep so your body can clean. It's like the vacuum cleaning time. It's spring cleaning at night.
So another woman under that, this is interesting. She says she currently has estrogen positive cancer. I have fibroids and sometimes it flares. Fortunately, it's not too painful. She does bleed excessively at times. She told her OB/GYN, I don't want surgery. Um, can you just remove the fibroids without hysterectomy? And we've already said, yeah, but this woman is interesting because she has estrogen positive cancer.
Yeah. So she's estrogen. She's got estrogen receptors on a tumor, or a adenocarcinoma. So a carcinoma. Probably unrelated, different receptors on that than you would have for the estrogen receptors on a fibroid. Not that, I don't know, and I can't do this off the top of my head. I don't know that a breast cancer, estrogen positive breast cancer patient would have a higher risk of a leiomyosarcoma or a cancerous fibroid. I've never read that that's true.
Maybe if the
But,
instances,
assuming, go ahead.
I was going to say, maybe if the inflammatory response is very high and also their aromatase activity is very high, that estrogen is getting exacerbated inside the cell, like all over the body.
Could be. But part of and I'm not up to date. I found this out. I'm way out of date for breast cancer treatment and who needs chemotherapy and who needs estrogen blockers and who needs radiation and all that. But part of the medical treatment or prevention of recurrence for breast cancer that's ER positive is an anti-estrogen. And if a patient was on an anti-estrogen, theoretically, they would be starving the fibroid as well.
Mhm.
So we know, for instance, if you put a woman who is prior to menopause on Lupron, so a gonadotropin releasing hormone agonist, it will downregulate the hypothalamus, pituitary, and the ovary and put that woman in reversible menopause. So her estrogen is typically less than 15 and her fibroids will shrink. So that would be an extreme way of doing an anti-estrogen. So Lupron shots come to mind.
Mhm.
Um, there's a pellet variety of that. So Lupron was FDA approved for prostate cancer in men, but it also worked for endometriosis. And I used it for women that had fairly, maybe decent sized fibroids. So I would shrink them for 3 months with Lupron, and that would decrease the blood supply and get rid of the estrogen. And then I would do the myomectomy. It was easier.
Mhm. Okay. There's another comment, and we're going to wrap up on this now in a minute.
So I don't know if that fits with her. I don't.
Sorry?
Okay.
So this
I don't
one,
know if that really pertains to the ER positive breast cancer patient, but
I think, I think I would hope they're probably doing some sort of aromatase inhibitor with this lady and progesterone, but you just never know now with conventional medicine's approach and everything that's happening.
I would think so.
Yeah, well, everything, all the conversation around hormones now seems to be so manipulated. We'll get to that when we get to our gaslighting section, but we'll just hope. So this other woman, well, this is pretty much what we just mentioned. This is a different comment, but she said, in gynecology, most women are completely unaware that you're prone to cysts and fibroids. You will also most likely have fibroids in your breasts, which I commented saying, well, yeah, because fibrotic tissue is inflammatory and generally systemic. So what do you think of that?
Well, same thing. Fibrous. What she's alluding to is fibrocystic breast. They called it disease, and it's at least half of women, so it's not a disease; it's a state. So fibrocystic breast change, which is probably estrogen dominant related, and some of those become, some women have fibroadenomas. They actually form little fibrous tumors in the breast, which would be sort of like a fibroid in the uterus, only it's in the breast. And it's a glandular adenoma, means gland tumor. Adenoma, gland tumor. Fibrocystic change is a cystic change, so it's not a solid tumor, but it's half of women. I don't necessarily, so they kind of got away from calling it fibrocystic disease of the breast because it's not a disease. It's not precancerous. It makes breasts difficult to examine, both by mammogram or self breast exam. They're hard. So the thing about fibrocystic breasts is women with that, if they will do self breast examination on a routine basis, they memorize their breast.
Mhm.
So I used to tell women, when you get in the shower, you're going to soap your breasts up. So just use your hands to clean, to wash, and you will, without even trying, memorize your own breast. And I don't know how many times women would come in and say, see that thing right there, that wasn't there 2 months ago. That's
Mhm.
what we would go after.
Mhm.
I'd
Yeah,
say, okay, well, let's ultrasound that and see what that looks like.
women,
I'm not a big
most
I'm not
women.
a big mammogram fan because the next test is an ultrasound of the breast. So why don't you start with that?
Yeah, true. So, okay, a last question here on this. This one was heavy bleeding. I've had several surgeries. Fibroids grew back fast and the bleeding was horrible. The hysterectomy she had performed contained 28 fibroids. And back to everything we've just said, well, if they keep growing back, there's an estrogen issue here. With everything we've said,
Yes,
estrogen, even right to the fibrotic breast tissue, there's an estrogen component.
right.
Okay.
So yeah, I mean, there are some women that hysterectomy is the correct thing to do. And
So
so
th
for her, that was the correct thing to do. She made an individual decision, hopefully with her doctor, and they came up with that. Okay, this is the correct uh, procedure. This is what we should do.
so she had
What I'm
multiple
against is
fibroids.
yes, and so what I'm against is, and this happens all the time. Oh, you have a fibroid. Let's do a hysterectomy
Mhm.
without any other conversation.
That's what I
I
was,
don't think that's fair to women.
yeah, that's what I was kind of highlighting. These women who have had hysterectomies, they've had multiple. Whereas if you just have one smallish or even medium fibroid that can be removed, that doesn't necessarily call for a hysterectomy.
Right. Yeah, if you have 28 fibroids, kind of like the 750-gram uterus, there's not a whole lot you can do that's going to be conservative surgery. So 28 fibroids, I would have probably said, there's no way I'm going to do 28 myomectomies on you. So I think if this is bugging you bad enough, it's causing trouble, hysterectomy is your best option. And I would do it vaginally if possible.
So we're done now with the fibroids, which I noticed, and I hadn't
Yeah,
noticed
you can.
before that I say fibroids and you say fibroids. I never noticed that before.
Oh, no, no. You say fibroids and you're Irish, and that is probably grammatically correct. FIBR should be fibroids,
Yeah.
but I've always said fibroids. And almost every English speaking American would say fibroids.
And I say estrogen.
You say estrogen, and I say, if you're looking at grammar and English rules, fibroid is accurate and estrogen would be accurate. So my fibroid is inaccurate and your estrogen is probably inaccurate.
So, okay, we're done with that. This one, um, this is not fibroids, but this woman said, I have another question. What about polyps? Specifically polyps that keep coming back in the uterine lining post-menopause.
Yes, I've seen that is probably so. Postmenopausal bleeding is one of my red flags for working up somebody, make sure they don't have cancer. The vast majority of the time, it was not cancer. I would find a polyp. So I would use a hysteroscope and look inside. And you'd see a polyp, and you just put a little grasper in there and just pull it out.
Mhm.
But if they keep coming back, you would think so they can't be estrogenic because these women are postmenopausal. So polyps, know, are pretty common. And one of the screening tests for postmenopausal bleeding, especially women on hormone replacement, is the endometrial stripe thickness. Should be 4 millimeters or less. Well, a polyp is always going to be, not always, but most of the time it's going to be bigger than 4 millimeters. And so you look. I was the looker. I mean, how are you going to know what's going on until you look? So I would look and I'd say, oh, here's a polyp. Pull that out. All that went away. The recurrent ones would be annoying, but I'm not going to say I ever had somebody that I did a polypectomy on that had a recurrent polyp. Maybe I just didn't see them long enough. I don't know. Maybe they moved and went someplace else and had more polyps. So recurrent polyps is not part of what I really dealt with. I'd find them, remove them, and then we were done.
I'm going to push back a little bit on this because anytime I've dealt with polyps, there's always an inflammatory issue in my clients, always, whether or not that's polyps in the sinuses, the uterus, or the anus. There's always inflammatory issues. And regardless if a woman is post-menopause or not, they can still be estrogen dominant. Most women have zero progesterone post-menopause unless they're doing replacement therapy.
Yes.
But to say that women make estrogen right up until the day we die, there's estrogen receptors and tissues all over the body, regardless if you're overweight
Right.
or slim. So I still believe there is an estrogenic component, but regardless, there's definitely an inflammatory component.
Well, yeah, anybody with a chronic anything has inflammation is probably the underlying cause. So I agree with the inflammatory thing for sure. Um, and then estrogen, yes, is you don't necessarily make progesterone. That's kind of the art of perimenopausal and menopausal hormone balance is trying to figure out, okay, so you get a person that's making estrogen, and if they do not have a uterus, most doctors will not put them on any progesterone, which I think is a mistake. Um, but if they do have a uterus, they're probably put on progesterone, and then you got to get the balance right. So it's always about a balance. estrogen and progesterone are they balance each other out to an extent. If you look at their action on the lining of the uterus. So too much estrogen, yeah, you're going to get too much bleeding, buildup, endometrial hyperplasia, endometrial polyps, all kinds of things.
So that is the perfect segue to what we wanted to transition to is gaslighting for women. And one thing you mentioned there is the biggest big fat lie women are being told. Well, one of them, in my opinion, is that you do not need progesterone if you don't have a uterus. And I know Carol very much is on the same page as me, and I'm pretty sure you are about this, that that's a big fat lie. You have progesterone receptors all over your body. Progesterone does not only protect the uterus, progesterone protects the brain, the bones, the breasts, everything, your feet, your heart. Progesterone protects everything. So when a doctor tells you, oh, you don't need progesterone or we're not putting you on progesterone because you don't have a uterus, they're either negligible or they're misinformed and uneducated.
Uh, yes, to all that. I mean, men have progesterone receptors. So Carol makes the argument that men should be on progesterone. And she actually knows more about progesterone than me. And I think she's smarter than me. But progesterone education is the problem. Hormone education in general is a problem. I'm not going to say it's negligence. That's just what they're taught. I mean, I was taught the same thing when I was a gynecologist. I just happened to have a mentor who was a reproductive endocrinologist who told me when I was a young doctor, women need progesterone all their lives. So don't listen to all that. You take the uterus out, you don't need progesterone. And she was specifically talking about progesterone, not that stupid Provera. That medroxyprogesterone acetate is a chemically all that is a horrifying drug. It's terrible.
I would argue that all progestins are horrifying, and this is another
Yes.
topic of gaslighting that women are being told that, oh no, your birth control, it's progesterone only. And I'm like, no, it's not. There's no such thing as a
No.
progesterone birth control unless you were taking mountains of bioidentical progesterone yourself. Maybe you could prevent pregnancy, and there's no guarantee, but otherwise, there's no birth control that only contains progesterone. They contain progestins, and progestins are not progesterone.
That is correct. That is accurate. Yeah. There is no such thing as a progesterone only birth control. Progestin, yes. So there's norlutate, there's a couple of others. Norlutate comes to mind. But there's different progestins, so chemically altered progesterone, but it is not progesterone at all.
As Carol puts it, these progestins, they are they were structurally designed after the bioidentical progesterone molecule, except the structure is upside down. So when they attach to the receptors, they have more estrogenic activity than anything else, because even though they're supposed to be structurally similar, the easiest way to describe it is the structure is upside down, so it doesn't attach the same as bioidentical progesterone does.
Right, that's true. That's a good way to describe it. Yeah, for sure. I
So
told
what?
you she's smarter than me.
So she's really intelligent. She really is intelligent. But what else bothers you as we start to wrap
It
up
is.
now? Like what else do you
If
feel
I ever,
women
if
are
I ever, well, okay. So this is a whole other topic too. But what you see, and I just did a review on a 50-year-old nurse who knows she's being gaslighted, who is perimenopausal. She is not menopausal. She has ovarian function, but she is testosterone deficient. So she's in the last 5 years, she's gained a bunch of weight, like 40 pounds, no motivation, no energy, no sex drive. She's had 4 children. So she said, my sex drive just disappeared. And her doctor told her, well, your test is 23. In most textbooks, the range is 20 to 80. So she gets an F on a grade, bell curve on a grading on a curve. She gets an F for testosterone level. And so she was told, well, you're just depressed. Here's some Prozac. That's what they all get told. Well, your labs or your hormones are normal. Here, take this SSRI. That is gaslighting.
Mhm.
Perimenopausal ovarian shifts are not psychotropic or psychogenic, they are endocrine. They actually do happen. And if you correct that and make their hormones optimal for them, you got to do it for each person. All of those symptoms that they're saying are psychogenic go away. That is the biggest gaslighting in women's health, is women in their 40s who think they're going insane. They think they're crazy, and they just have ovarian dysfunction. You got to figure out what's going on with their hormones. But if they go in there and they see a doctor who doesn't know anything about perimenopause or doesn't believe in that, they're going to walk out with an antidepressant every time. That is gaslighting women. Almost all women in their 40s. That's the biggest gaslighting that I see. And that has kept me busy as a health coach. I deal with women all over the country that reach out when I say stuff like that, and they go, that's exactly what happened to me.
Mhm.
And they're mad. They get angry when they figure out, oh, this doctor doesn't know anything about hormones, so let's just knee jerk put them on an SSRI or an antidepressant, which makes things worse. Then they can't feel anything.
Mhm.
You
Oh yeah.
think their sex drive's bad before, just because of their testosterone, you put them on an SSRI, it just goes away. They don't feel any emotions. So that's the gaslighting I wanted to allude to. And gaslighting about fibroids kind of fits in with that. You have a fibroid, you have to have a hysterectomy. That's gaslighting.
One thing I see a lot that I
I
would
don't think they do it to men as much, but men don't go to the,
no, not unless they have to. They're being brought in on a stretcher.
yeah, men go to the doctor. Men will go to the doctor when it's time to call 911. That's how
Yeah.
it works.
Yeah. So, one thing that bothers
Yeah.
me a lot, and this is what I would consider gaslighting, and it's very prevalent in Canada the last few years. I don't know about the States, but it annoys me a lot, is women are going to their doctors, and their doctors not only have no idea about the reproductive hormones, they have no idea about the corticosteroids, specifically adrenaline. So, women are presenting these symptoms of high adrenaline and they're getting prescribed Adderall and ADHD medications and like stuff that they don't need, where they actually would have just really benefited from some bioidentical progesterone. But this is because the doctor doesn't understand what's happening, is not reading the symptoms, and now they're walking away with an ADHD diagnosis. And I have a real problem with misdiagnosing people because now people become their diagnosis. And that is their excuse for feeling the way they feel. And again, you probably just needed some progesterone.
That is true. Very true. And of course, cortisol overproduction and cortisol resistance is rampant. The other thing people don't realize is when you put a diagnosis like that on a younger person, when there are instances where if you have a diagnosis like that, you can't get life insurance. Specifically, if you've been diagnosed with depression, I mean, you can't be a pilot. You can't get a pilot's license, but the insurance industry thinks, oh, they're more likely to unalive themselves. So it's doctors just willy-nilly put a diagnosis on people, and that can come back to haunt them later in life. So
Hmm.
I kind of like symptoms. I don't putting a diagnosis on somebody is saying you have this. Well, maybe you don't. Maybe you have, well, I'm fatigued. Fatigue. How many people say I'm sick and tired of being sick and tired? So that's called fatigue. That's a symptom that they can't hang on your head and say, oh, this person has major depressive disorder and they are a life insurance risk.
Yeah, I agree.
Make sense?
Yeah, absolutely. I agree. This was another awesome talk. I think we covered a lot on fibroids, Dr. Tracy. I think it's going to be really helpful for people because there was definitely confusion there. Where can people find you, contact you, follow you?
Oh, Health Without Risk across all platforms. And on the profile page is a direct email to me. So I read all my emails. I
Hmm.
get many of them. So give me, I always have to say, give me a little time. I'll get back to you.
Hmm.
The worst way to get a hold of me is to direct message me on a platform. I get too many of them to pay attention. So if I don't hear from an email, if I don't get an email, I'm going to miss you. So Health Without Risk, every major social media platform. And there's a way to get a hold of me.
Well, thank you. I'm sure we'll have you back in another couple of months to discuss something else. We have a whole list of topics. I hope you have a great day and thank you for your time today.
Thank you for having me.